Hi, good afternoon. My name is Christopher Seymour, and I was invited to the ISICEM to speak today. I'd like to thank the conference organizers and all of you for your attention. I'm an associate professor of critical care emergency medicine at the University of Pittsburgh, and I direct a program in translational and clinical science. So today, in this session, I'll be addressing how will AI change sepsis management. Okay, we'll go over a few points in this brief talk. One is why sepsis, and why is it an opportunity for artificial intelligence? And then we'll briefly touch on what we might be able to do to nudge physicians towards their best care. Okay, so the first question is, why can't we just rely on the clinician? Is there really a need for an adjunct to our own bedside care? And, this is not a new concept. We've been studying different ways to improve care of patients for decades. This is actually a New England Journal paper from 1982 about an algorithm called the internist, which was meant to assist in making the diagnosis for difficult patients on the medical ward. Now, they didn't have the computer power 50 years ago as we do now, but this was developed, interestingly, at the University of Pittsburgh and went through a variety of tests, including implementation at the bedside. So there's a historical precedent for this brief 12-minute talk today. I thought this was an interesting anchor for the discussion. So this is what the world looks like in the ICU. We have computers, monitors, all kinds of machines assisting the patient in creating data. And the question is, can that data, in fact, change our approach to sepsis patients and perhaps improve outcomes? This is some work years ago which established our definition for sepsis with an international consensus shown on the slide, that sepsis is an infection with a dysregulated host response and some organ dysfunction. This is a life-threatening emergency. There's a clinical imperative with millions of cases worldwide and thousands and millions of dollars being spent on the care of these patients to try to improve outcomes. It's notable that in our studies in sepsis 3, as well as continued epidemiologic studies in the most recent years, that 1 in 5 patients with sepsis don't survive their hospital stay. Those with shock, of course, this is much higher, and those presenting with milder symptoms have an improved outcome, albeit with long-term consequences. And over the past, few years, a greater understanding of the host response has not actually translated into new therapies. So molecularly targeted treatments, such as Aridiran, tested in the ACCESS trial, or activated protein C, tested in PROWESS shock, as shown here in these Kaplan-Meier curves, were not associated with improved outcome. A great opinion piece here asking in JAMA, why do sepsis trials continue to fail? And perhaps we, might be looking outside of molecular therapeutics and perhaps to tools like artificial intelligence. So part of this relates to the fact that no two sepsis patients are actually the same. There are differences in demographics, host response, site of infection, pathogen, organ injury, and even tolerance to that host response. On the other hand, our current approach to treatment of these widely variable patients is really one size fits all. I think this is exemplified most in the, quote, Our One Bundle that's been advocated for by the Surviving Sepsis campaign, where all of these steps are recommended as best practice, some of which are evidence-based, others which are not, in folks who present with sepsis despite all of the differences we just described. So is that optimal? And amidst this complex presentation, are physicians actually acting in the same way? Well, this is a nice epidemiologic study by Ethan Pelton from the US, where he looked at almost 45 physicians in the emergency department and looked for across comparable patients with similar patient characteristics, the time from ED arrival to antimicrobial initiation. A very simple study. And what you see ranked from left to right is that for similar patients, physicians are actually doing things quite differently. There might be some who are waiting almost 3 hours to administer their broad-spectrum antibiotics, where others are getting in the door after only a few minutes. Perhaps there is an opportunity to reduce this variation and improve outcomes with different adjuncts. And so will computers come to the rescue? If you've picked up anything in the lay press or even a variety of medical journals lately, all we're hearing about is artificial intelligence in healthcare. There's billions of dollars being invested by our industry partners in this field, thinking about ways, whether in radiology, pathology, or even at the bedside, of augmenting our clinical decision making. So there are a whole variety of types of, quote, artificial intelligence, whether it's from prediction of the onset of a syndrome, splicing a syndrome using machine learning into different types, or using reinforcement learning models to guide treatment decisions. Here's one example of the Seneca study, which was published last year. And this was our group looking at different ways to unpack the variability in sepsis. And I'm going to take you on a little bit of the story and then bring this back to artificial intelligence at the end. And so the Seneca project was, in fact, to determine clinical sepsis phenotypes using electronic health record data at presentation. The hope here was that there could be easily accessible clinical characteristics that could separate patients that might be different in their biology as well as their outcome. There was mapping of these phenotypes to different clinical trials to see whether treatments were modified by the presence or absence of the phenotype. And we'll get into some of that. So in this paper, it's now about a year old, there was unsupervised machine learning to derive these phenotypes, and lots of clinical variables available to the physician was included only from the first 6 hours of care. Using a bit of a supervised selection method for the features, you can see that things like lactate, blood pressure, race, gender, and others were included in the models. So what came out of this black box? So the machine learner then took all patients shown on the left in black and was able to separate them into 4 what we think are relevant clinical phenotypes, shown here in the red, blue, green, and purple. Now, what do those patients really look like, and were the clusters themselves different? That's shown here in these chord graphs. And although you're unlikely to be able to read all the bits, what you can see is that on the bottom are the phenotypes. Those are the different colors. And the chords are traveling to different organ systems that were under threat in those patient groups. And really the take home is that these chord graphs don't overlap. There are differences that the machine learner found. And so when we looked at these from 30,000 feet, you can see an alpha, beta, gamma, and delta that had sort of different labels based upon the pathophysiology of those groups. In different trials, prowess, access, process, and a cohort study, GENOMS, which you could look up in the manuscript, we looked at the different biomarker profiles. And on the log scale, you can see based upon color that the delta phenotype in blue had markedly abnormal biomarkers of inflammation, even endothelial dysfunction and coagulation, compared to the other phenotypes. A further readout was how stable our trials were if these phenotypes had been included in the design. So we took the process trial, one we're familiar with at the University of Pittsburgh, and imagine what would happen if there was a lot of the delta phenotype enrolled instead of what was actually observed. On the other hand, we asked what would happen if only alpha patients were enrolled, and we used simulation to try to unpack the effects. So the left-hand column here is a scenario in moving left to right when more and more delta patients would have been included in process. And what you see in the bottom panel is that instead of the neutral result on the left-hand side, all in gray, simulation showed us more and more we would have seen harm at the conclusion of the trial. On the other hand, if we included mostly alpha patients in the right-hand column, moving from left to right until the entire trial was in alpha, we actually might have concluded for a benefit from early growth-directed therapy versus usual care, really showing that these trial results in our knowledge was unstable to the states of the patient that were enrolled. And so that brings us to this AI clinician. It's interesting to think about how these are named, from the internist in 1982 to the AI clinician in 2018. But Matthew Komorowski and his colleagues at Imperial College London used reinforcement learning models to map treatment decisions about fluids and vasopressors from a model compared to what clinicians actually did in both MIMIC as well as an additional data set. And this is their schematic of sort of the process, but a portion of the MIMIC data was taken. A treatment matrix was developed based upon patients either getting a lot of fluid and a little vasopressor, or perhaps the opposite. There was an unsupervised k-means model used to derive patient states in 4-hour blocks. And then they developed what was called an optimal policy. And this is using an MDP model, reinforcement learning model, that attaches rewards to the model's decisions over time, and developing what ought to be the best case scenario for that patient traveling through time as it relates to their treatment. Then, in a validation set as well as a test set, they compared their model to what the clinicians actually did. And that's shown here in one of their many results slides, where the difference between the clinician's policy and the optimal AI policy is shown on the x-axis, and the mortality is shown on the y-axis. And so this is in the test set. So in validation, they found that when patients spread out from the 0 dotted line and either got more vasopressors or less, or more fluids or less compared to the optimal AI policy, outcomes tended to be worse, and in particular when fluids were given in excess of what would have been recommended. And so, across these different states in this treatment matrix, you almost could imagine that certain treatment combinations ought to match up to different phenotypes, perhaps, that were described in the Seneca study. And that potentially is the future that we see in AI in sepsis care. So we can argue about, well, what's the best way to define a state? Could it be using an unsupervised model that clusters as informed by biology, or perhaps using a very complex model that's not relevant for the bedside, but splits patients otherwise? That's yet unknown. And so as we wrap up this very short sort of introduction to the topic, I would submit to you that sepsis is common, deadly, and heterogeneous. And a one-size-fits-all treatment really ignores the complexity of the disease and this treatment heterogeneity. There is emerging reinforcement learning models and machine learning studies that are uncovering phenotypes all the time, in fact. And it's how they're combined that we think we can optimize decision making. Now, there are many challenges. One does not just create an MDP model and then translate that to patients. In fact, there's an intense amount of HCI, or human-computer interface studies, that need to go into adapting a model set of recommendations to clinical practice at the bedside. On top of that, there's really interesting federal regulatory decisions around these living models and how AI can be tested. There's a beautiful piece by Derek Angus in JAMA about using randomized trials to actually develop evidence around the use of an AI tool. And that's certainly worth a read for more information on the subject. And finally, implementation and uptake of these at the bedside is the key to their use in patients and deserves study as well. So with that, we'll wrap this first talk. Thanks for your attention. Certainly going to acknowledge some contributors to the science here, as well as the team at JAMA, who has published many of these articles along the way. So thanks for that, and we'll look forward to discussing.